Sure. Hi, everyone. My name is Vijay. As Walter mentioned, I'm a research associate here at HSPN. So I'm just going to spend a few minutes talking about, how we've reported on some of these indicators and go into a little bit of detail on how to interpret some of the graphs that you have been sent in your PowerPoint presentations. So each of the 53 OHTs, they have received a PowerPoint presentation which presents their OHT results. And within that presentation, we've actually included a little bit of sample interpretations that we hope you find very useful when you're looking at your data. And each OHT also would have gotten 3 different Excel spreadsheets, which contain their own OHT's raw data for 20 different indicators. And we've done it stratified by 3 meaningful subgroups. So we've done it by Chi-High population grouping, by BC matrix system, and by primary care model. So I'm just going to spend a little bit of time walking you through a few components of the PowerPoint presentation that each OHT received. So there are 2 sections for these reports. The part 1, the first section, provides your OHT's ranking, and it's being compared to all other 52 OHTs on 10 overall improvement indicators, as well as 5 improvement indicators for 3 common target populations. So we focused on mental health, addiction population, the frail and older adults population, as well as end of life population. And as Walter mentioned before, this is not available for the provincial report because, again, it's for OHTs that are being ranked against each other. And the second section of the report that Walter will focus on provides your OHT results for 12 indicators stratified by 4 different useful subgroups. So we've done these 12 indicators by material deprivation, primary care model, Chi-High population health grouper, as well as BC health system matrix. And the 12 indicators that HSPN chose to visually represent was just identified as being the most important to OHTs at this time. So I'm just going to focus on the first part of the PowerPoint presentations that we've gotten. So these are just a list of improvement indicators that we looked at when we were ranking all of the OHTs against each other. And you can see there's 4 major headings or subgroups. The first one is we have 10 overall total population improvement indicators. And we look at things like premature mortality, ALC days, ACSC hospitalizations. And then moving on to mental health and addictions care indicators, we look at things like the number of patients that had frequent, so more than 4 ED visits for MHA, as well as repeat ED visits for mental health as well. And then for older and frail adults, we again have 5 improvement indicators. We look at falls, that ED visits that were, related to falls, as well as caregiver distress. And lastly, for palliative and end of life care, we look at things like deaths in hospital and ED visits in the last 30 days of life. So we did use spider diagrams to help rank each OHTs across all these various indicators for both 2021, 2022, and 2022, 2023. So you'll see a sample of these spider diagrams in the upcoming slides, but typically the light gray lines, they kind of look like a spider web. They highlight the actual ranks, where closest to the center indicates the best rank among all OHTs. And then data points that are furthest from the center, they indicate the worst rank in comparison to the other OHTs. Each indicator is oriented so that the best performance is always closest to the center, regardless of whether the best is represented by like a very high absolute score or a very low absolute score. So we're always trying to get to our point to the closest to the center. And one thing I really did want to highlight is that spider diagrams measure performance relative to other OHTs for each year. So your OHT could end up in a situation, for instance, where they could have performed better in 2022, 2023 compared to the previous year. But if on average, all of the other OHTs also performed better in that specific indicator, your point on your spider diagram could actually be further away from the center. And it looks like you've done, a little bit worse in the next year when that's just the relative score, whereas your absolute score could have been higher. So in general, when it comes to spider diagram interpretations, we're trying to be small, we're trying to be close to the center, and on target is better. So we're just going to go through a few examples of spider diagrams that actually represent, actual OHT spider diagrams. So for here, we have a spider diagram that's looking at this particular OHT's performance for total population indicators. And as mentioned, we have that light gray web that indicates the ranks. The light green points represent the OHT's performance for 2021 and 2022. And the darker green represents the OHT's performance for 2022 and 2023. So you can see here, this particular OHT seems to have some issues with ACSC hospitalization, a few issues for avoidable ED visits as well, and slightly less concerning issues for continuity of care. Particularly if you look at ACSC hospitalization, this OHTs have ranked lower compared to the other OHTs in 2022, 2023, compared to the previous year. So you can kind of see the dark green is a little bit further out compared to the light green. Whereas this OHT seemed to have ranked very similar for avoidable ED visits. And then for continuity of care, you can see this OHT has ranked slightly higher than the other OHTs compared to the previous year. So overall, when this OHT is kind of looking at this spider diagram, they should absolutely look at other population-specific reports for additional ideas, but definitely something that they could focus on is ACSC hospitalization. So this is a sample spider diagram for our mental health indicators. As you see, we have 5 of them. And starting off with the top center, the first contact in ED for MHA, this OHT seems to be doing fairly okay, and the ranking is quite consistent for both years without really much change. Alternatively, when you look at the frequent ED visits and repeat ED visits, there's a little bit of a flag that this OHT ranks fairly lower. As the point is quite far from the center. And another thing to note is they've ranked lower compared to the other OHTs in 2022, 2023 compared to the previous year. Moving on to how the spider diagrams look for feral and older adults. Again, we have 5 different indicators for this. And the one I'm going to focus on for this specific OHT is the fall-related ED visits. You could see that this OHT performed better than most OHTs for this fall-related ED visits, and they've been ranking quite high consistently for both years as well, as the point is very, very, very close to the center. And this is just another example of another spider diagram for end-of-life indicators. And I just wanted to end off by saying, the spider diagrams really look very different, and these are just different examples of how much they can vary from OHT to OHT. But if you want to take a look overall as how an OHT is doing, you want to ideally aim for a very small web. So if we're going to take a look at this, for example, if you want to look at the first diagram, the one on your top left, you could see it's quite large. They rank last for some indicators such as virtual visits. Alternatively, as an OHT, what you ideally want to aim for is kind of something like the middle bottom diagram where the points, yeah, we are jealous of the middle ones. The bottom diagram where the points are very close to the center. The actual diagram is quite small and it's on target. This is just a reflection of that, they're ranking consistently high for a lot of these indicators. And that was just a brief introduction into the spider diagrams as well as how to interpret them. I'm going to now hand it over to Walter to talk about part 2 of the report.
How did we pick 12 indicators to focus on? So I think this is of use to people to know, as we've produced Excel data sheets that have 27 indicators, and we thought that's going to be too much. And so we did some field work on collecting the 12 indicators. So here is what we did. And I'm just going to share this around now. So we distributed surveys to an OHT representative. We have an OHT evaluation contact, and we wrote to all of them and said, who is the best person to provide input on the data that we are sending out? And so that might have been the evaluation lead. In some cases, it was somebody else within the team. There were 56 OHTs invited, 42 responded, 75% response rate. Most of the respondents held positions as executive directors or leaders in analysis or population health. And the OHTs were asked a little bit around how we had provided the data before and if they wanted something similar or different. And then we asked them to rank the importance. So we forced, and everybody didn't like doing this. In fact, I think we had one team refuse to do this, is to rank the priority of the indicators in order for us to be able to focus in on those things that are most important to the Ontario Health teams themselves. So this is one of the questions we asked. Do you think it'd be better to have a report that provides a full set of indicators for one of the existing sets? So go in and say, frail older adults, mental health, 5 indicators, overall indicators, CQIP only, and or provide a report that includes a limited number of indicators. And overwhelmingly, so 65% of the respondents said that we should provide a report that includes a limited number of indicators from each of the above. What are some of the results of the top priority indicators? These are shown ranked. We had a 10-point ranking from most important to least important. Most important is shown in the bright green on the far left. So we really looked at what proportion of people said this was the most or second most important. Looked a little bit at the third, but mostly we made the decision based on that. And so you see here, if we drew a line somewhere around 25% of the indicators beating more than 25% being the top 2 priorities, you see ED visits best managed elsewhere, continuity of care, and ambulatory care sensitive hospitalizations. I'll say I was disappointed that cost per month alive didn't make it to the top of the list. I'm a health economist for those people who weren't aware. But I appreciate that these are areas that are somewhat looking upstream and towards a more integrated and population health approach, which is quite helpful, I think, for Ontario Health teams. It's not just specifically within an organization such as a hospital. They do relate to hospital use, but I think the way to help solve these problems is through strong partnership with community. So I was pleased to see these ones. From the mental health, we again had high frequency and repeat visits being suggested. Within the older adults, only one really made it up into that top range, being repeat fall-related visits among those identified as frail. The other ones, not to say that this isn't an important area, but it wasn't a common area of importance across all OHTs. So everyone will have their own indicator result for all of the frail older adult indicators in that spider diagram. But in all of the different stratifications, we focused on those ones that were most common across all teams, and that's for our provincial work, and then also for your own team's work. And then for the end of life, we had palliative visits in the last 90 days of life and ED visits in the last 30 days of life. Finally, from the CQIP indicator set, ALC days, PAP test, and up-to-date mammograms, and the rate of ED visits as a first point of contact was actually included from the mental health one and here. So that is an indicator that is included in the reports. So here are the indicators, and you see where they came from now, the top chosen ones: ED visits best managed elsewhere, ACSC hospitalizations, physician continuity of care, 3 in the mental health area, 3 from the CQIP area that are not reported elsewhere, 1 from older adults, and 2 from palliative and end of life. So that's where you said we should land. So one of the big things across the indicators is to look at stratifications. So knowing how your overall OHT is doing, that is interesting. Honestly, possibly not very useful. Without starting to understand, well, in which populations are there specific areas that we could prioritize in order to help us improve on this indicator? Because, you know, we have a population attributed of 450,000 people, for example, or 200,000 people, or even 35,000 people, and we don't know where to start. So the point of the stratification is to give you some places to understand, either according to what characteristics of clients, so patients, that by material deprivation, their relative socioeconomic status, lots of social determinants of health might play a role here, or also by the type of primary care they have. So OHTs are, in their premise, primary centered and based out of primary care. That's how people get attached to an OHT, is through their primary care provider, if they have one. And so that's another way. And then the other two are according to client health needs or client health conditions, I'll say. And we have two of these. So material deprivation, this is the graph on the right shows in each OHT the proportion of the population that live in most deprived neighborhoods versus least deprived neighborhoods. So a low deprivation quintile, the very bright green, that is a relatively wealthy neighborhood, not a lot of deprivation. Those indicators that go into the deprivation index are shown on the left side of this screen. And the places that have the dark blue represents the proportion of the population living in areas that have the highest deprivation. So you actually see quite a bit of variation going from almost 40% of the population in one OHT that is in the most deprived area to that actually being less than 10%. So quite a bit of variation as we look across the Ontario health teams in the material deprivation. And we relate this to the indicator. So in which indicator does this make a difference? It doesn't make a difference in every indicator, but it very much is relevant to some. The other is around primary care enrollment models. Hopefully most of you are familiar with Ontario's primary care enrollment models. Could be family health-based team, or there are several sort of blended capitation models, capitation through family health networks or organizations. And we also put into this group the other grouping, so mostly rural and northern models, because they're capitation but not always team-based care. And then we have other models right through to people not being rostered to a primary care physician. The other ones are around healthcare. So we have whole webinars that we've run on the CI-HI and the BC Health System Matrix. So we had CI-HI here to explain back in somewhere around September 2022, I think, to talk about how their grouper is built. And we use the 16 health profile categories, and you'll see what some of those names are. And the other one, because this is very administrative, it's built on healthcare utilization. Another one that we use is the BC Health System Matrix, which is built out of an idea of people encounter the healthcare system with different needs. And it takes sort of, are you trying to stay healthy? Are you getting better? You had an acute condition. Do you have to live over the long term with chronic illnesses and conditions? Which conditions? How complex are they? Or are you, frail, older, and heading towards the end of life, being up at that top kind of area where we think there are the highest needs? So this is another model of looking at your client population. So what our intent is to do all of the indicators according to all 4 stratifications. So you can imagine that amplifies itself quite quickly. And so we wanted to select out those most important 12 indicators out of the whole 27 and show them across all of these, all 4 stratifications to help you understand, is ALC coming mostly in your end of life, or is it mostly from cancer patients, or is it mostly from people with adult major time limited conditions? So you can find out where you need to be thinking about putting in interventions. And here I'm showing you the stratification by primary care model. Again, all 4 are shown. So as you can see, ED visits best managed elsewhere. This is for all of Ontario. You'll have your own. The overall Ontario average here is 10.1% of ED visits are ones that could be best managed elsewhere. You see here that that is actually about at that point for the people who are not rostered. Family health groups, so it's loosely affiliated physicians on some capitation with some after hours care. That actually is the lowest rate of ED visits best managed elsewhere is among that group. And actually we see the highest, maybe counterintuitive, ED visits best managed elsewhere coming out of family health teams. So you might want to have a look within your own results to see, is that true, or which primary care groups? Because it seems that perhaps those people might be having more difficulty getting access, getting in to their team, or they're not as aware of the things that they can go see primary care for. Could be a couple of those different reasons. So again, there's quite a bit of variation. That's 3-fold variation differences depending on where the individual is receiving care in their primary care group. So a next one was continuity of care. I'm not going to do them in order. I will get to ALC after. So continuity of care, this is the simple way of just saying what proportion of your visits were to the physician you saw most often, almost always a primary care physician. So you see here that it does vary. So people in long-term care who mostly have a designated most responsible physician, 75% of their care is being provided by that individual. People with cancer who have a new diagnosis and are seeing many, many different people through the course of that illness are then actually at the lowest point, which is not terribly surprising. What one would hope is that after they receive cancer care, that they can resume a more normal. So people do not stay in these categories forever. Hopefully they'll come out of the cancer care system and fall back into one of the other lower needs groups where we have slightly higher continuity of care, but not brilliant. There's quite a bit of work to suggest that continuity of care can be helpful in people to manage their chronic conditions. The way we measure it here is around relationship. There are other aspects of continuity of care, management continuity, information continuity, which is something that sort of came up in our digital health webinar as well as an important aspect to fixate on. So this is just one of these around continuity of care, and we can have more discussion. So here's ALC days. This one I've decided to show by the BC Health System Matrix. I've also kind of picked these so you get a flavor of each of the different stratification groups. So here you see that ALC days are, and here you're counting total days across that bottom axis. So all acute days are the dark plus the bright green, and the bright green are the proportion of those days that are ALC. So we see actually a lot of the total ALC days are coming from that high chronic and frail population, which are very often individuals with both multiple complexity from medical as well as social and functional conditions. So I don't think there's a surprise, but there's also a group that are near the end of life. So perhaps the pathway to secure their care outside of ALC might be different than the ones that have other conditions. And then we also see just people with high chronic conditions without considerable frailty are also generating a good number of ALC days in the overall province. So compare your own OHT's results. They will not mirror this. They may be a little bit different. Okay, and the last one we are going to stop on, which was ED visits best managed elsewhere. Oh, that actually ALC days is here also by the POP group methodology, which is a little bit different. You see a little bit less emphasis here in palliative because it requires people to have palliative care as opposed to really being more designated near the end of life. So here we're showing it by the Chi-High POP group methodology. And so you can see here that if you look at the total numbers of people, some people here were known to have some other related mental health condition in their history. If they didn't have it in the prior year, then they get categorized as an ED because the look back on this indicator is only, actually, I think it's 2 years, whereas our look back in ascribing people into Chi-High is a little bit longer. You also see that a lot of the people, in fact, the majority of people are in this minor acute category. So these are people who are encountering in the health system for acute issues. Could be a pneumonia that's primarily ambulatory, could be like a small fracture. Again, minor acute, it'll resolve quickly. Those people are otherwise relatively healthy, and we are missing the fact that they have mental health conditions when they're being managed in the community, and they are ending up in the emergency department with those conditions. So we've got to think about what are some screening opportunities to catch people up front and offer them the navigation to better services. And I know that a good number of OHTs are focused in this area specifically. So that's one of the things, is to find those populations. And there are still people throughout that people have moderate chronic conditions, and they will be in to see their physicians more often, but they're accumulating a smaller proportion. And the people who had no contact at all with the health system, those are going to be difficult for you to find. Those non-users, those are people who the prior year had no contact with the health system, and then they show up in the emergency department. That's going to be a more difficult group to identify in the community, except through some population health initiative. How to use the reports. We have this comes right out of the decks. Have a look at that spider diagram, seeing which indicators your OHT appears to be close to the center. Here you're doing well as compared to other OHTs. There may be opportunities to improve, but you won't be able to easily find that from looking at other OHTs. Using the spider diagrams to see which indicators your OHT appears further to the outside, in that case, you know that many other OHTs are doing better than your OHT. Is that something that's important to you? Because you also have to think about, this is an area for improvement, but is it also a priority for our OHT? Do we have people that are willing and able to actually make generate and make a difference that would relate to improving this indicator. So what does this indicator represent? Is that important to us? In which case you can use the provincial report forthcoming to find which other Ontario health teams are ahead of you, and maybe find out either from our webinars, because we do population-specific pieces, through communities of practice will be a great opportunity for you, through the Ontario Health sponsored communities of practice, which are supported by other support groups like the RISE, like Ontario Health, like ourselves, in doing it. And then, thinking about indicators where the Ontario Health teams are most important, you can also look at that second part of the report by primary care model, material deprivation, or health grouping to find out where you have that greatest opportunity for improvement. And those subgroups starting to point you to some of the conditions you need to look at beyond what you've just been doing in the past around improvement. So focusing that activity. You may need additional outreach, for example, in low users or non-rostered patients. That's a different approach if you need to work within a family health team to better access care for that. So that's part of the uses of these. Every Ontario health team has received, someone in your team has received Excel data files with all 27 indicators, their main, stratified by 4 approaches for fiscal years 2021-22 and 22-23. We will be posting all of these by February 15th online. For now, the person that we had as being your most contact. So you can email us. We've caught a few people in the chat, but you can also email oht.evaluation@utoronto.ca for more information. We'll find out who in your OHT received the reports. And we are making a simple online comparator tool to be able to create charts based on the HSPN reported data. So for example, OHT A and B, comparing emergency department visits best managed elsewhere according to a primary care model. And then we still need to go and find out what it is about those 2 OHTs that are different and drive those results. This is data to inform decision making. This is not decision making.